Okay, welcome back everyone to our next session here at the Mid-Atlantic Virtual Summit. This session is a presentation entitled, as you can see here on your screen, The HIPAA Problem You Didn't Know You Had and How to Fix It. This session is being brought to us by our partners at Caroline. If you haven't had a chance quite yet to check out our virtual booths, I encourage you to do so and to take a moment and check out Caroline's virtual booth. They have some great educational content as well as contact information there if you would like to learn more about their initiatives and offerings. For those of you who are just now logging in for the first time today, all of our sessions were created to be as interactive as possible. Our faculty members are ready and waiting for your questions. In order to submit a question, if you do have one during any of the sessions today, just utilize the chat functionality within the Zoom platform. All of these sessions today are being recorded and will be available on demand by this evening. Okay, so now I would love to introduce our presenter for this next presentation, Subha Aaron Javia, who is the founder and CEO of Caroline, and also an associate professor at Penn Medicine. As the founder and CEO of Caroline, Subha brings over a decade of research on the intersection of technology and clinical workflows, as well as experience as an associate CMIO at Penn Medicine. Subha, take it away.
Great. Thank you so much, Matt. Really appreciate everyone being here and excited to kick off the conference with all of you this morning. As Matt mentioned, my name is Subha. I am a hospitalist and also founder and CEO of Caroline, and I'll be talking about the HIPAA problem you probably didn't know you had. And the reality is that the way we deliver care over the last 15 to 20 years has fundamentally changed, where we no longer have one person who knows, or one team who knows everything about a patient. It's really dozens of different teams and specialists and clinicians who are working together to care for a patient, which is great because we provide much better care that way, but has created new challenges where sometimes the left hand doesn't know where the right hand is doing. And our EHRs have clearly made a lot of improvements in the last couple of decades. We started using secure messaging, but we really haven't fixed this problem, which leads to situations like this, real patient story at a place with a fully integrated EHR where a patient was admitted with pneumonia. On day 4, her intern came in the morning and said, I think she's ready to go home today. So he wrote that on his paper list, which is how we all manage our work on the inpatient side. And put that order into the EHR. A couple hours later, the attending came in and said, actually, I think she doesn't look as great as I was hoping she would. I remember she has a history of a GI bleed. We should check a hemoglobin or a blood count before she goes home. So that attending wrote on her paper list a reminder to tell everybody, but before she could tell anybody or talk to anyone or text anyone, she was pulled into an emergency. That happens all the time. So this message now was trapped in her pocket where no one else could see it. Meanwhile, that discharge order went in. The rest of the team moved forward. And of course, the patient went home and ended up getting readmitted 2 days later with a GI bleed, went to a new hospital, new team. They didn't know she had just been admitted with pneumonia, that she needed to be on antibiotics. They focused on her GI bleed as they thought they should. You have another new team in a couple days. And now, of course, she has a fever and a cough again, which is because she wasn't started on antibiotics. They start ordering all of these medications, all of these tests, which is all extra and wasn't necessary, and honestly could have been avoided had that team had access to the information that they could have through a shared list instead of paper list that no one could communicate with. So this is really what I am talking about, is that communication failures are really a problem in medicine. They contribute to the vast majority of preventable errors that occur. And it's because of this challenge of so many people taking care of patients that our EHR is not really meeting the need of what clinicians are doing on the front line to take care of patients together, which leads to inefficiencies and errors. And the reality is that the big events that we see, like the one I talk about, are really just truly the tip of the iceberg. There's a ton more of near miss events that a lot of people just tolerate as the status quo because it feels impossible to change, but honestly isn't okay when we think about our family members being in the hospital or being cared for. And the true magnitude of the problem is really honestly unrecognized when we think about how these errors have ripple effects downstream. So I found myself wondering, how did we get here? How did we get to this point of making of this being such a problem? And as I mentioned, medicine has changed, but our tools really haven't caught up. They're kind of, if you think about how most EHRs are structured, they're basically electronic or digital recreations of paper charts instead of really leveraging what we can do. And as a result, we are still, as clinicians, doing a large portion of our work on paper. It's kind of one of the biggest secrets in healthcare, that minute to minute, day to day, you can ask any clinician in any setting, they have paper that they're using to manage what needs to get done, whether it's for rounding, whether it's for handoffs, whether it's for, keeping track of the tasks that they've done. These are real examples, or this on the left is real examples. And the problem is that these are essentially workarounds and they're not secure. Sometimes they're emailed to each other, they're put on file sharing sites that they shouldn't, they're printed, people are sending text messages, often not secured. Just to give you an idea of the magnitude of the issue, so we actually measured how many of these papers that people are printing every day in hospitals. It's on average about 23 pages per patient per day, which means that in a health system or a hospital with about 10,000 admissions, they're printing about 1 million pages every year. And if you think about each page usually has about 10 patients, it's about 10 million potential HIPAA violations if any of those papers get left around or texted in a way that they shouldn't have. And that's a reality. So these are, again, real examples that we've seen or people have sent us of papers that are left in all these different places. And again, these are all well-intentioned providers trying to do the best they can to take care of patients, but unfortunately their tools aren't giving them what they need to be able to do their minute-to-minute work. So, the question is, how do we get people, especially busy clinicians, to change their behaviors? It's really hard. A lot of people feel like they're on app overload. We tackled this problem at Penn in my work over the last 10 years and really tried to take the approach that we need to make it easy to do the right thing, for clinicians to do the right thing for patients. And the basic way to do that is to design for delight and to give people a carrot instead of a stick. And there are some basic principles that we focus on, which is user-centered design, supporting dynamic workflows. A lot of things that we often do in our foundational EHRs is static or transactional, but care is really dynamic and happening throughout the day in a very fluid way. Incorporating best practice and clinical decision support right within people's workflow so they don't have to go search for it. Making things intuitive, easy to use, easy to access. So mobile is a huge part of why people use paper, because they can't use their EHRs well enough on mobile devices. And then a big one is responding quickly to workflow changes and requests from clinicians so that as their demands and on their own time and their practices change, we're able to respond quickly to that and really support it. Because at the end of the day, if we can save people time, they're going to make less errors and do less of this work on paper workarounds. When you think about how other professions do this, in other industries, there are a lot of project management platforms that teams use to be able to keep people focused on their work and efficient. These tools are all focused on usability and designed specifically for workflow. As you can see, there's suites of applications and they're all interoperable and easy to access. In fact, even people developing our EHRs use these platforms like Jira so that they can actually work together as a team about what needs to get done. So I'm going to tell you a little bit about how we approach this at Penn, and I want to make sure there's time for questions. So, starting with the problem that we were tackling, as I mentioned, was these paper workarounds for handoffs and rounding lists. And prior to this project, we were using an EHR-based application, which actually my team developed prior to that for the 10 years before the initiation of this project. But the problem is our EHRs are, they're really been built off of reporting, coding, billing, all these very important things about the business of healthcare. But they're not really designed for the delivery of care. They're great for usability in certain aspects, but not for frontline clinical care. And I think it's no surprise that there's a lot of dissatisfaction on the clinician side using EHRs. And when we think about how we do documentation, workflow, data visualization, which we've added into EHRs, they are way better than paper charts, but they're really not meeting, I think, the needs of what we need for today's medicine and where we've gone over the last couple decades. So the solution that we decided to work on was, to take what we are doing in the EHR is the business of healthcare. It's the legal record. It's the source of truth. It's where our documentation lives. But design something that works alongside the EHR for the delivery of care and replacing what we're doing in paper lists, in unsecured email, in file sharing sites and text messages, and really creating a structured way to do all of this work, like a project management platform, in a way that then is standardized across all of our services, is not unsecured, and is transparent and is able to be seen both within teams, between teams, but also by administration. So some of the things that we focused on designing into the application as we worked on this at Penn was making it very easy to access team lists and being able to say, it doesn't matter which floor I'm on, which service I'm on, which hospital I'm in, I can easily see the list of patients that I need, and I can integrate with the EHR to bring those in, or I can make them custom. And then just with the single click of a button, I can see more information about everyone on this list, about the things that need to get done. Again, this is all information we would either be typing into a free text box and printing or writing on paper. And then every person has their own copy of this. So what we wanted to build was a way for everyone to have a shared workspace to be sharing this information. And then you have your patient views. And for example, the patient view here is for this one patient, being able to bring in the information integrated from different EHRs. So vitals, labs, meds, making it easy to access and available at the bedside, at the point of care, where people have to make decisions. So instead of taking about 20 clicks and 13 minutes, it's taking 1 to 2 clicks and seconds that you can do either on your phone or within your EHR on the way to a patient's room, as you would with paper. Sorry, my thing keeps jumping around. So some key components of the patient page is having quick access to important patient information, having patient level task lists. So I can just see, what do I need to do? What do you need to do? What do they need to do about the patient for the patient's care, and making sure that we're all on the same page. And then we created a way to actually bring all of that information together and drive it into a progress note. There's so much double documentation, triple documentation that we do, writing on paper and gathering information from many different sources and putting it into the EHR. We wanted to make sure it was very easy for people to be able to do that without having to write things twice. So a kind of basic tenet is less clicks. And if you write something once, you shouldn't have to write it again and again. So we built this note generator where it takes all the work you're doing all throughout the day as a team. And instead of you having to then write it all over again, at the end of the day, you can actually just say, create my note out of this. And it puts it all together for you as a starting point. And people using this say that they cut down on their documentation time by 50%, which was great, something we hadn't actually anticipated being as successful as it was. So just some results from our approach and what we built. So first of all, I think everyone feels kind of app fatigue and says, we've invested all of this effort and time and money into our EHR. We don't want something else. But starting off from this place of realizing that, well, everyone was using other workarounds and other things outside of the EHR, and by putting it together, we're actually going to make things more efficient, really played out in how we implemented. So our adoption was very rapid across all of our sites, across all of our services. It's in use on over 160 different clinical services. It's been about 7 years now, but on average, we have about 4,000 unique users a week and who have cared for over 400,000, almost 500,000 patients in the application. And usage has really been interdisciplinary. So you can see in this breakdown, 40% of our unique users are trainees, and 30% nurses, 20% advanced practice providers. But it really helps people get onto the same page about what needs to get done instead of working off of separate individual lists. And a quote from one of our nursing users actually was that they have a much better understanding of the patient's plan when they look at this team workspace, which means that they don't have to call the intern constantly or call the team constantly to find out what's happening, because they can see in real time what they're working on. So, do people actually use it? The answer is yes. So when you look at how much people are actually managing tasks as a team, and other things that need to get done within the applications, on average, people are editing tasks about 280,000 times a week. Again, that breakdown is, in terms of task editing, is mostly trainees, but then you also have advanced practitioners and attendings. That averages out to about 20 times per day per patient. People are editing tasks. So if you think about all of those edits being done on paper in a place where you can't access it, you can't have any insight into it, you have no control over where those papers are, it gives you kind of a magnitude to this problem of managing all of this on paper outside of a system that you can access and control. And about 120,000 times a week, people are actually updating these one-line summaries or the information about the patient. This was actually way more frequently updated than in the EHR rounding list or in the EHR handoff, because it's mobile and easy to access. And so that actually translated into better documentation and better outcomes. So we actually looked at the new application that we built versus the old one that we built before that within the EHR, and overwhelmingly people felt safer using the new application. And you can see there was a statistically significant improvement in people feeling that the new system was safe, that they were satisfied it, and that they would recommend it to their colleagues. And then, its growth really grew. We had originally built this as a rounding and handoff tool for teams, but people are using it for more than that. So they are using it for transitions in care. But as I mentioned, a lot of usage for writing progress notes during rounds to make decisions while pre-rounding. A lot of usage also off campus, people saying that it's easier when they're on call, instead of bringing home all of those papers in their pockets, in their bags, into their house where they shouldn't have all this exposed patient information. They're able to just pull it up in the application that we developed and communicate with the teams in the hospital, look at data in real time in a way that was faster for them than getting into the EHR or looking at the paper lists. And then they are using it at the bedside. So, people are using it to update and look at their handoff information. But what we find particularly exciting is that clinicians are using it to actually answer questions from patients or to show patients their data, which they are doing quite a bit, and really bringing the patient into the conversation. So at the end of the day, clinicians say that they save about an hour every day using our application. I think my favorite quote by far was an attending who said we would have to pry it from his cold, dead hands if we wanted to take it away from him. I think it's rare to hear attending clinicians speak like that about technology in healthcare. And about 3/4 of our users can each point to a time when Caroline prevented errors in their own practice. And at the end of the day, that means they feel safer taking care of patients. That has translated into improved HCAP scores at the sites using it. And when doing specific patient satisfaction surveys, that has gone up as well. And then at the end of the day, all of that contribute to a better bottom line for the health system. And with that increased information that's being captured instead of lost on paper, it really has driven improved documentation and improved reimbursement opportunities. And did we actually reduce paper usage? So yes, over 80% of the teams are no longer printing paper lists at all. About 20% of teams are, and those are particularly in areas where Wi-Fi wasn't, or cell signal wasn't as strong, like in the OR or in the ER. Although those teams are still using it, they just also print paper to have it. But overall, we reduced paper printing so much that at an annual savings about $1 million and about 180 trees. So when we think about, I like that fact in terms of helping the environment. And this is just an idea of what people liked most about using the application is really access to information and that it's easy to use. So I'll open it up to questions, and I see there's one about is Caroline updating the EHR? So yes, when it comes to viewing the objective data, so vitals, labs, meds, radiology imaging, care team information, that is read only. So we are pulling from the source, whether it's one EHR or 10, which we have done, it brings it all into one view for the patient, but we're not writing that data back. So we don't change the systems workflows around, getting vitals, getting labs, and where that goes. We're just reading it, making it easier to access, making it easier to understand. When it comes to the planning and creating the care plan about what needs to happen for the patient, then yes, that can go back into the EHR in the form of a progress note. There aren't really discrete data elements in the EHR to send this back to, for in terms of tasks or FYIs or anticipatory guidance for handoff. So it's really, and it gets captured in the form of a progress note. And yes, it is HIPAA compliant. So the application itself is HIPAA. That's actually, sorry, one of the biggest points is that so the entire application is HIPAA compliant. It's hosted on a private cloud that's in the same cloud that HITrust is hosted in. And then, it's not the legal record. It is a handoff in a clinician workspace. And then when you put it into your progress note, then that becomes part of the legal record, and it's all HIPAA compliant. I would welcome any questions.
Yeah, I was just about to say, no, go ahead, Soup. I was just about to say, any other questions from our audience?
Or if there are other solutions that people have tried, I'd love to hear them. I haven't seen any other EHR-based solutions that were not paper-based, but if there are any, I'd love to hear about them and how they've worked. Or if any of you are wondering if this actually happens, I encourage you to go back and ask any of your clinicians, just ask them, do you have paper in your pocket or a list in your office, or walk around your hospital and or outpatient office and see if you find lists of papers laying around. I would bet that you would find them everywhere. And again, I think everyone's doing their best. But this is really, I think, an unrecognized workaround that is a basic part of how we practice that hasn't been fixed.
Absolutely. Well, thank you, Suba, and thank you to our partners at Caroline for supporting the Mid-Atlantic Virtual Summit and for supporting this session. We now have another short break before we have our final session of the day at 2:30 p.m. Eastern Time, which will be a fireside chat that we have with Geisinger. And it will be on telehealth growth in 2021 and beyond. So take a short break, respond to some emails, take a drink of water, eat some late lunch. We will see you all back here at 2:30 p.m. sharp. Thank you very much.
Thank you, everybody. Thanks, Matt.
Yep, take care.